Afternoon, everybody. It's good to see you virtually, at least. I wanted to take this opportunity, as always, to thank you all for all of the hard work that you've been putting in. I don't even know how far into this we are now, 3 weeks or so, and I very much appreciate your questions and the interest. And I wish I had more time in the day to be able to answer all of your questions and be out there as much as I'd like to be. But as you can imagine, things are still a little hectic here in the health department. So I appreciate your patience with us. Um, Overall, I think as I step back for a moment and look at where we are in this, I feel like we're, to some degree, in a calm before the storm. When we look at the data, and we'll talk a little bit more about that, I think there's a temptation to look at this and say, maybe we're doing all right. And I think there's good reason for that. That conclusion is rooted in the data that we are seeing. My only caution is that until this is over, I hesitate very much to spike the football, so to speak, because I feel like we have such a long way to go in this. And as we'll talk about, I feel that the data that we're able to report right now is still very preliminary. Any of the estimates that we are making are what I would call unstable still. There's a lot more that we need to learn. There's a lot more understanding that we are working to achieve. And, while we can provide some reassurance that I think our social distancing measures have had an impact, I say that because we haven't seen a major spike in this community yet. I think the social distancing can be thanked for that. I also want to offer some, guarded optimism that, we are not done with this, and I think we need to keep going with our social distancing efforts, and to the extent that we can, step it up, because the worry that we all have is that complacency will open the door to something worse, and so that is certainly not where we want to be. With regard to the confirmed cases, I can't remember now when it was, but we are really trying to improve the amount of data and the understandability of the data that we're offering on the dashboard. You should see every day an update around 4:30 of the confirmed cases, and we report that in a number of ways so that depending on your appetite for data and graphics, that may be of interest to you. We are also reporting the daily hospitalization numbers as well as the ICU numbers. I will take this opportunity to clarify that when I count an ICU patient, it's somebody on the ventilator. As we've seen throughout this epidemic, a number of people, particularly early in the epidemic, were being hospitalized in an ICU type setting, even though they were, in terms of acuity, more appropriate for regular floor. And that's largely because of the way things work in the hospital and operations and so forth. So what I'm trying to report to you in the ICU number is mechanical ventilation, which I think is important from a service allocation standpoint, as well as from a general understanding of where we are in the epidemic standpoint. And as you know, obviously, yesterday we reported for the first time some rather early estimates, some data on how the COVID-19 epidemic is impacting various race and ethnicity groups in our community. And so by now, I believe you've all seen that. I want to highlight a couple of findings in that I think are worth paying attention to. And with that, I will say that these are early findings. And part of my reason, and as you've probably learned to appreciate about me by now, I treat data very seriously, and I also think it's important that we get it right. I do not want to report data that are so preliminary that they will tempt us to lead up the wrong tree. I don't want to misconstrue the message. And I think we have a general understanding of where we are as a community with regard to disparities and so forth. And frankly, I would anticipate that we should see those disparities to some degree in the data that we are reporting. So that being said, I think there are some interesting findings that we can at least say preliminarily from the data that we reported upon yesterday. As you know, we reported on hospitalization rates for non-ICU patients, as well as hospitalization rates for ICU, i.e. Ventilated patients. And then we also reported the data on the deceased in this community. I will point out that among the hospitalized patients who are not in the ICU, Black individuals are 27.9% of the hospitalized patients in this community currently are African American, as compared to 16.2%, which is their proportion in the general population. And for Hispanic individuals, it's 18.6% of our current hospitalizations, which is interesting given that 9% of our county is Hispanic. So we have roughly a twofold more likely chance of being admitted to the hospital if you're a Black or Hispanic from this community. When you look at the ICU admissions, interestingly, African American residents of this community are 3.3 times more likely to be admitted than their proportion in the community, though interestingly, Hispanic residents comprise only 5% of the ICU admissions, whereas they comprise 9% of the population. And then the final statistic that I think is worth mentioning, though I will say it's probably also preliminary, but when you look at the deceased individuals, the proportion of the various race and ethnicity groups parallels that that you see in the community. So I say all this with the same caveat that I think it's early. These data I would not necessarily say represent reality. I think they represent the early reality from what we're seeing. But I think given that this epidemic is really still in its infancy, I hesitate to draw any major conclusions. You know, with this data, we're going to do some more thorough analyses. We're going to age adjust these data to better understand the role that age plays. We know that age has a major role in how people do when they become afflicted with COVID-19. I also want to take a look at this geographically to the extent that that might be a proxy for population density within the city and in the suburbs and rural areas. That is an analysis that we're trying to understand as well. We're also going to dig deeper into the test data. We did not report yesterday on the proportion of...
Now, how do I unmute? I want to ask him a question.
I'm hearing some whispering.
Yeah, Mary, can you please be on mute? Thank you.
Oh, sorry.
On the proportion of tests that were performed within the various race and ethnicity groups. I've got a lot of questions about this, so I'll just answer the question right now. Why aren't we reporting on test data with regard to race and ethnicity? And the answer is that we don't have those data. The way these race and ethnicity metrics are paired with the results is at the lab level, when the lab submits the slip that goes to the lab where it's processed and the data are ultimately entered, the race and ethnicity box is left in anywhere from 50 to 75% of instances. So in order for us to do that, we either have to manually enter all of the race and ethnicities to the extent that we know them, or we have to do modeling, which is a little bit more complicated. So we're working on that because we certainly want to make sure that we're testing equitably, but we don't have data to argue one way or the other on that as of yet. So what I will say on the issue of disparities is that, you know, we anticipate seeing disparities. I mean, there's no reason we shouldn't. And to that end, we're preparing. We want to prepare for what we anticipate because we know in this community that there are zip codes that are separated by 4 miles where life expectancy differs by almost 9 years. So there is no reason to anticipate that we will not see health and healthcare disparities in these data as they come out. So our job is to pay attention, as to prepare, and is to prevent, to the extent that we can, identifying individuals before they become ill, especially across our diverse population, I think is the goal. And part of the goal behind releasing these data is identifying that every community is at risk, to try to dispel some of the misconceptions that this is only an illness that afflicts certain race and ethnic groups, as well as to dispel the myth that this is only an illness of the older adults. While it is true that the majority of people who are hospitalized and who are succumbing to this illness are in the older age groups, there is no data whatsoever to support that the young among us are not impacted by this. And so we want to get out there and highlight that young individuals can be infected with COVID-19. And I think that was an early misconception that it may still persist, but that is certainly something that we want to address. But when we start looking at the breakdown of how this epidemic will impact our diverse community, I think it's worth bearing in mind that we know that minority communities suffer disproportionately from chronic illnesses, and we have every reason to believe that's going to play into how our community evolves with regard to COVID-19. We know that access to healthcare is not equal, is not equitable across our community, so that's something that we need to pay attention to. And particularly around, you know, issues around a communicable illness, access to housing and access to the ability to properly self-quarantine and self-isolate, I think is not something that is equally distributed across our community as well. And so when we say go home and isolate, you know, I think we have to be a little bit more thoughtful as a community and certainly as a health department. We want to make sure that we are offering options to individuals so that they can have access to self-isolation and self-quarantine. And when we say, you know, things like go to the store only one at a time, we recognize that that's not practical for everybody. If you're in a household where there's one adult and one child, it's probably impossible to go to the store by yourself. And so those are the factors that we're really trying to dig into. And I think having the data available is a first step. I think it's only a first step. I think we have a lot more work ahead of us to really understand how COVID-19 is impacting the diversity of our community. But that being said, I welcome your questions and feedback.
We're going to give the first question to WXXI.
Hey, Dr. Mendoza, it's Brett.
Morning.
Good morning. Thanks for providing this data. Good afternoon. Thanks for providing this data. I talked yesterday to the CEOs of Action for a Better Community and Common Ground Health, and both of those people said that we should have anticipated the disparities in health outcomes for racial minorities, and that it's not surprising to them at all. Why did it take until now for us to start publishing this data and start explaining what the disparities are and why they're occurring?
Well, I'm not surprised at all either, and I have a great deal of respect for Wade Norwood and Jerome. I'm not surprised at all. You know, my hesitation, frankly, I was expecting there to be a disparity in death by race and ethnicity, and that it wasn't there made me wonder whether there was something wrong with the data. And so going back to my earlier point about I have a responsibility to report accurately, I dug in and I looked at every single one and I looked at the charts and I wanted to confirm that what we were actually seeing initially was correct. As I mentioned, a lot of this process was manual, and I had to do a lot of work to be able to pull these data together. And I take it very seriously that we get accurate information out there. So, you know, whether it's early or not, doesn't matter to me. What matters is that it's right and that we're accurate and that we're sending an accurate message to the public. Because the last thing we want to do is send the wrong message and have to dig ourselves out of that. So, you know, I take the responsibility of reporting data very seriously. And so, you know, we reported it when we reported it, and I think, you know, we had enough numbers really by yesterday to have more confidence in it. But I certainly didn't want to release anything prematurely, certainly at the risk of getting it wrong.
Can I ask a follow-up?
Everybody gets one question, one follow-up.
Okay. What then is the response from the county health department? What can the health department do to alleviate, at this point, when we're already in the epidemic, to alleviate some of those disparities? Or is it too late? Is this something that we're just going to have to deal with and recognize?
No, we absolutely need to be proactive about this. I think the first step, and this began actually this morning, we had a conversation with Trillium, Anthony Jordan, and St. Joseph Neighborhood Center to try to understand how can we identify people in minority communities earlier in the course of their illness. You know, if getting infected is perhaps something that's less able to be amenable to prevention, can we at least prevent people from presenting later in their illness? Can we help them to access care earlier? Can we test them a little earlier, given the caveat that testing too early is not going to be helpful? But if we can identify people, encourage them to come to care, encourage them to isolate, offer options for them to isolate more appropriately, that I do think will make an impact on preventing hospitalizations and ICU admissions and the need for ventilators. So I absolutely don't think it's too late at all. I think there's a lot that we need to do.
Thanks.
Again, just to clarify, we're going to take one question, one follow-up from everybody on our list here. Next, we will go with Spectrum News.
Yes, good afternoon, Dr. Mendoza. It's Mary McCombs.
Hello.
This is my first Zoom meeting, so sorry about the mute button, but I found it. I'm just curious if we can ask questions outside of what you're addressing with the racial and ethnic breakdown.
You can try, sure.
Okay. My first question is, how long after the peak do you think this is going to return, and how do you prevent a second spike? Because we're now hearing of a second wave of cases being reported in China.
Mm-hmm. So there's a couple of questions in your question. The first is that the spike, we shouldn't resign ourselves to a spike. The spike is what happens when you, throw your hands up and stop social distancing and, have a giant party together. I think that's not what we want to have happen. And I think what we're seeing right now is really a smoothing out of this spike or this plateau, so to speak. So to the extent that we can continue with social distancing, we will push off the spike. Ideally, we push it out long enough that it's not actually a spike, but really more of a hump or a speed bump. So, how we behave today will predict how we do in 2 to 3 weeks and in 2 to 3 months. So it's not a foregone conclusion that we're going to have a spike. That being said, most people believe, and I believe, that we're going to have a surge of some kind, and it's going to die down in some fashion. Depending on what that looks like will determine, the presence or the emergence of a second spike. What will also determine, the appearance of the second spike is how we reopen Monroe County to normal life. If we decide we want to open up all the doors and all the schools and all the businesses and restaurants all at once, that would not be a wise choice, because that will not allow us in the health department and across the community to go back to doing the aggressive contact tracing and isolation and quarantining procedures that we had a couple of weeks ago. So, we want to be very careful about how we return to normalcy, and how we do that will determine whether we get that second spike or not.
Okay, thank you. I guess my follow-up question was, I know you touched on it just briefly now with trying to reopen things, the status of schools and any recommendations. I know they've been taking it a slower approach and, giving different timetables in terms of when schools in Monroe County might reopen.
Well, there is no science to this, unfortunately, other than to say that, in our circles, between myself and my counterparts across the state, in general, we've always viewed 6 weeks or 2 to 3 incubation periods, but 6 weeks in this case, as sort of that period that we need to sort of wait before we start calling things all clear. And that would be 2 to 3 incubations or 6 weeks after a spike. So if the spike happened tomorrow, and there's no indication whatsoever that would be, we would still have to count forward in time 6 weeks, which would put us toward the end of May. And, theoretically, you could open schools at the end of May, but that would not be well advised because of all the reasons that I had outlined earlier. So, I've been meeting every week with the school superintendents, having this conversation. It is a big pill for everybody to swallow. But the reality is, I think that window of opportunity for us to be able to reopen schools before the end of the school year is closing.
Thank you so much, Dr. Mendoza.
Next is Patty Singer with the Minority Reporter.
Okay, unmuted. I saw something from a governor's briefing that the DOH is working on an antibody test. We have talked about that before. In light of disparities, in light of what you said about access to care in certain parts of our community, should that test be available, how quickly can it get to all aspects of our community and not those who are just plugged into care?
So whoever just coughed is not on mute. Sorry to blow you in there. To the question of an antibody test, none of the antibody tests that I'm aware of has yet to be validated. So all the antibody tests, and I believe there's one that's even available locally here in the Northeast, none of them has been validated, which means that if we were to deploy those tests, they would still need to basically be backed up by something more reliable. And that more reliable right now is what we're doing right now, which is, we can't presume immunity in anybody. So we're taking precautions equally across everybody. So when we have a valid, accurate, effective test, ideally one that's been approved by the FDA and all the other regulatory bodies, we will try to deploy that equally across the community. And I frankly would want to focus on areas where we know we have not done as good a job ensuring access to care. Documenting immunity is very important for frontline workers. And we know, particularly when we think of ethnic and racial minorities, structural racism has put people of color on the front lines disproportionately. And so I think we would want to screen those individuals more aggressively for immunity because I think it matters. It would matter to reopening our economy, and it would matter for getting people back to work and ensuring their paycheck and so forth. So, but I think it's too early to have, detailed conversations about that because we don't even have a test yet. But when that test is out, I would absolutely want to focus on underserved areas.
In the self-isolation issue, you mentioned that there are people who can't do that because of their living conditions. What's the situation at the Clarion, and are there other sites available for people, and what's the census in those?
I think the census this morning is in the single digits. So we have capacity at the Clarion Hotel. And so I connected with St. Joe's Trillium and Anthony Jordan this morning to say, if you've got patients, if you've got clients who may benefit from this, give us a call. Because I would much rather have that hotel filled than to go dormant, because I have every reason to believe that there are going to be challenges in achieving a quality quarantine or isolation across our community. So I would rather we use that resource more.
Thank you.
Eddie. Next, Democrat and Chronicle.
Hi, Dr. Mendoza. Thanks for taking our questions. This is Steve Orr from the newspaper. There's, as you mentioned, a surfeit of African Americans who are in ICU compared to their proportion in the population. Yet no such bubble, if you will, in the death category. Does that could that ICU number indicate, those people who are on ventilators, indicate that perhaps the death number the disparity will show up in that death number sometime soon?
I think it's too early to say. I think I would want to dig in a little further to understand what are the clinical factors that have them on the ventilator in such high numbers. Is it that there are a differential proportion of lung disease, underlying lung disease? I'd want to look at the length of time on the ventilator. All I have is a total percentage based on literally a snapshot of one day. But I think to answer that question more rigorously, we need to do more thorough analyses. But certainly we know that people who are on the ventilator in the ICU have a poorer prognosis than people who are on the floor, all other things being held equal. But I think what I would want to challenge is that assumption that all other things being held equal. We'd need to dig into that a little bit further.
Thank you. The other thing I wanted to ask about, and first I wanted to warn Julie and Steve that I'm going to send them an email as soon as we're done, because I have a question about the numbers that's too complicated to even pose here, just about the way they were compiled. But the thing I did want to ask is, you said something when you were discussing some of the outreach that is being done that made me wonder if you were indicating that people of color have not been appearing, presenting themselves within the healthcare system to doctors or hospitals until they're very sick. You suggested maybe you're missing people in that community or those communities early on.
Well, that's only an assumption. And I make that assumption because we're seeing a higher proportion of people of color being hospitalized. So when we look at general illness and the patterns of hospitalization, when you present to care is a major predictor of when your likelihood of being hospitalized. I don't have any empiric data to support that other than my clinical experience as a physician and having taken care of a lot of people in the hospital. That is my impression, and I would be surprised if it was any different here.
Thank you.
News.
Did you say News 8?
Nope, Jeremy, City News.
Oh, thanks. Yeah, I couldn't understand the channel either. I think you might have just answered this, but I'm going to ask it again anyway. Do you have any sense for why there is such a disproportionate number of African-American patients in the ICU right now?
I don't. I would want to look at the data more closely to be able to understand that. I think anything at this point I would offer would be conjecture. So I would rather take a deeper dive into that. Like I said, the first thing I'd want to look at is age. If the average age of the African-American patient in the ICU is 15 years older than the non-African-American, there's a reason. But that's the kind of thing I'd want to dig into further.
Do you think what you're talking about with reaching out to populations of color, do you think that'll help bring those numbers down, or?
I hope so. You know, I hope so, absolutely. I mean, I wouldn't try it if I didn't think it would work. And at the same time, I think we need to try because we have good evidence from other segments of healthcare that trying is important and that these interventions do make a difference. So, you know, I'm borrowing from my experience in other areas of clinical care to assume that it will make a difference here as well. But these are new times. I mean, this is an epidemic. This is an epidemic of a communicable illness. You know, this is a very different thing than a chronic medical illness or an exacerbation of a chronic medical illness. So there's a lot that we're learning about this epidemic that will be new, that we can't apply what we know about heart failure, diabetes, and COPD to. So there's a lot that we need to learn still.
Thank you.
Thanks, Jeremy. WROC, your turn.
All right. Hi, Dr. Mendoza. So I have a question regarding something that the mayor mentioned yesterday in her press conference. She mentioned that she had talked to you and the county executive about social distancing grading, I guess it's called. And she said that 2 weeks ago, Monroe County had an A, and now Monroe County has a C. And I was wondering if you could just give us a little bit more context into that, where that maybe comes from and what you know about it.
So to give you the background that I do know, there are websites that utilize anonymously, I'm told, sort of cell phone tracking data. It's what gives the traffic maps, so to speak, on the Google Maps and so forth. So, you know, to the extent that that's a proxy for anything, I think that's the first caveat. But assume that that's accurate and assume that that's, you know, a valid way of looking at things. It is true that 2 weeks ago, our grade on these sites was an A. And then more recently, it's turned down to be a C. When you look across the state, urban areas tend to do better than rural areas, which I don't think says anything about urban versus rural. It has something more to do with how people move in various types of settings. So, you know, on average in cities, we drive less than people do in a rural setting. So when you look at all the data, when you break it all up, the area where we seem to be struggling the most, at least compared to where we were 2 weeks ago, was in parks and recreation. You know, our marks with regard to how we're doing in large public spaces has gone down. And, you know, the question that nobody can answer on these websites is, are people going to parks and observing appropriate social distancing? I don't think those data on these websites is able to elucidate that. But for what all this data is worth, there you go. We are not doing as well as we were 2 weeks ago. And given that we don't really have a good measure of social distancing other than the anecdotal, you know, reports that we hear and pictures that we receive, you know, what I would offer is, you know, we all need to do better, and we probably all could do better, you know, whether these websites say A or D. So, you know, I think that is something that we are talking about as a county, is how do we educate primarily? Is there a way we can deploy education in a more thoughtful way, in a more targeted way? And then, you know, we don't want to get into this, but we may have to, you know, the question of, do we enforce? I think that is a tough one, because we certainly don't want to have to be punitive, but at the same time, you know, a lot is at stake, and if we don't do this right, the consequences can be grave. So that is the challenge I think that we have before us.
All right, thank you. And then my next question, unrelated, but as far as nursing homes go locally, we've just been hearing that some nursing homes have cases, and we're just wondering, are those included in the daily numbers? And from what you know, what's your judgment of the situations in local nursing homes?
You know, nursing homes represent perhaps the highest risk population that you can imagine. Generally speaking, they're going to be older individuals. They're almost always going to have chronic medical conditions, and they're living in a congregate setting all the time. You know, that is a perfect milieu for a communicable illness. So, and I will say that the nursing homes really led the charge with regard to precautions. I mean, they were limiting visitors before hospitals were. They, you know, with all that happened in the Pacific Northwest, the nursing homes locally were very much keyed into what's going on. And so it really is no surprise that we're seeing outbreaks, so to speak, in various nursing homes. I think that's to be expected to some degree. You know, what can we do to prevent it is the question. And so, I've been approaching the nursing homes really from a coaching standpoint. The reality is that the State Department of Health is who has the official authority over all nursing homes. So, but here as a local health department, we have people closer, to these nursing homes. We have relationships with people in the nursing homes from a leadership standpoint. Most of what I've been able to offer is guidance, leadership, PPE, education around the guidelines and so forth. And I will say the nursing homes have been working very hard to implement those guidelines. And it is still true that there are a number of cases in nursing homes across our community. So it's a real challenge. It is absolutely a challenge.
Thank you. Next, we'll take from 13 WAM.
Hi, Dr. Mendoza. How are you?
Good, Tanner.
So earlier this week, we were seeing a lot from the Surgeon General. He's calling this the so-called peak week. I'm not sure if you agree with that or not on a national level, but what are you seeing? I mean, do you agree with that even locally, or?
I'll tell you, I'm not paying attention to the national as much as I probably should, but I am paying attention locally a lot. I see no evidence of peak week here at all. And I'm not sure that I even see it across New York State, to be honest with you. I mean, we have experience with communicable illnesses here in New York State every year. And so seasonal flu, to the extent that there is very little that we can compare flu and coronavirus with. But if you think of the communicable illness sort of spreading across the state, I do think that is sort of happening here, where downstate happens first, and then you see the more populated counties upstate happening next. And so we have seen that with downstate first, Erie County and us and Onondaga primarily being, following suit. That being said, I don't see really a temporal relationship that we can predict between downstate and upstate here, and not certainly between New York State and the rest of the country. So if it is peak week in the country, I'd be surprised, because I see a whole lot of the rest of the country that is still not yet impacted by this. But here in New York State, I would still anticipate that if we were to have a peak, even under the worst of circumstances, I would still predict that would be at least 3 weeks off, 2 to 3 weeks off. And like I said, I don't want to see a peak. I would much rather prevent the peak. And that's my goal. But there's certainly no evidence of it being a peak right here. In fact, like I said at the beginning, I think it's really more calm before the storm here in Monroe County.
Follow-up I have for you. You kind of mentioned that maybe going back to somewhat normal life 6 weeks after any spike, or at least any quote-unquote peak. I mean, let's say that happens to be June, mid-June, assume that for this question. As we start to think about life after the peak, I mean, what do you think this new normal could look like around the area, just in terms of businesses, schools? I mean, just from a health perspective.
I predict that we will be very cautious. I think we have to be cautious. I think we have to be approaching this as though we don't know what's around the corner. So I would anticipate that we will not do anything quickly. We will not do anything without a lot of conversation. I will grant that there will be a lot of impatience when people think that this is in the rearview mirror. We're going to want to, I mean, trust me, I'd love to go back to going out to the park and having dinner in restaurants all the same. But the reality is that if we do that too quickly, we put ourselves in danger. And we put our loved ones and our vulnerable seniors and others in danger. And that's the last thing we want to do. We've come this far, and we frankly haven't come that far yet. We're 3 to 4 weeks into this thing. There's a lot of this that's still yet to come. And I see us approaching life with a lot more caution. I see us questioning a lot of the conventions. I had somebody say, are we going to be able to shake hands and hug one another again? I have no idea. I sure hope so. But the reality is that those are questions that we haven't even yet begun to entertain, because of all the uncertainty and all the things that we're still learning about, where we are here on whatever day of April it is, April 9th.
Thank you.
Okay, last is WHEC. Thanks for your patience.
No problem. Hi, Dr. Mendoza. I wanted to just drill down a little bit more in the data, if possible. I'm wondering if when you're looking at it, you're seeing any particular underlying conditions more than others, and whether that has any impact in who is actually making it to the ICU.
In fairness, I would rather have the chance to look at that and give you a numeric answer. In having reviewed the charts though, preponderance of lung illness, absolutely. Cardiac conditions, almost always. But I mean, that's almost true for anybody who's in their 80s. So, you know, I think the preponderance of chronic illnesses, you know, what puts people in the ICU here is acute respiratory distress syndrome, or ARDS. And that's a condition that is very hard to live through, even under the best of circumstances. So I think the initial insult here is the COVID infection. And what's giving people a lot of hard time is the cardiopulmonary complications that they come in with that make it hard to recover from this. So generally, yeah, I think that's the most important predictor is the cardiac and the pulmonary complications. That's been pretty common as far as we can tell.
And back to the racial disparities for a moment. Do you think that that has any tie to the lack of testing in those early weeks, and just the fact that you really weren't testing people until they were in the hospital, or if they were a healthcare worker, or, you know, elderly, you know? So I'm wondering if, because there wasn't a test readily available that folks could get, you know, if they weren't feeling good, do you think that led to some of the numbers?
It's hard to say. Again, I'd like to see the numbers before I make an answer to that question. But what I would say is that there's no reason to expect that the disparities that we know about in access to care would be any different here. You know, I think testing is only a piece of that. And, you know, as we go forward, I think the more important part of the testing is the clinical evaluation. You know, the test as we know it now is not a perfect test. And I would rather reserve judgment to look more closely at patterns of access to care. I would say that's a greater predictor, and I wouldn't expect it to be any different for this than what we would see for any other conditions. You know, I think, you know, communities of color don't have the same level of access to primary care. They don't have the same level of access to urgent care. In general, I think they tend to access care later in the course of illness. I think that is true. And back when I was in Chicago, I did research on that topic, and it was true there too. You know, those principles I have no reason to believe would be any different here. But I think I want to dig into the data and understand that better before I give you a scientific answer. But my impression is that there's no reason to expect that disparities would be any different for this. And frankly, I think that this condition is shining a light on the disparities that we know about. I think if we don't heed the opportunity to address disparities of care and disparities in health as a result of this unfortunate epidemic, I think we will have missed a giant opportunity as a community.
Okay, thank you.
Sure.
Thanks, Jen. Did Will Astor make it onto the call? No. Okay, well, that's going to wrap it up. I don't know if Dr. Mendoza has any final thoughts.
I'm sorry, I am here.
Okay, floor is yours.
Okay, am I on now?
Go ahead.
Yeah. First of all, I'll offer an observation. What you said about the Parks and Recreation, our yard happens to open onto Highland Park, and we definitely have observed an uptick in people walking in the park, and I would say an apparent lack of social distancing, although you're probably seeing people who live together anyway. So, but that's purely anecdotal. I have a question first about, can you say anything about where we stand in terms of capacity? In the earlier press conference, you and the hospital officials laid out stages. I thought I heard Kathy Parinello say that we were entering stage 2, and I'm getting indications anecdotally that we're at least into or well into stage 2 now. Can you say, oh, you're doubtful of that?
Yeah, no, I think we're really more phase 1, and I would say the different hospitals are looking at, I mean, they have different physical plans. So phase 1 at U of R is going to look at, you know, different than phase 1 at regional. But, you know, Kathy is right. They are looking at phase 2, which is taking advantage of non-traditional but known clinical spaces for routine patient care. And whether it's COVID or non-COVID is still a topic for debate. But, you know, looking at Sawgrass surgical centers, other places where there are already equipment in place, beds and IV poles and the whole thing, monitors, looking at those places, that's the next step. I don't believe that they've actually activated that level formally, but I know that they're making preparations, and there may be a handful of people that are getting transferred around, but very much in that phase one, if not, really end of phase one sort of area. And then I think regional is very much in phase one as well.
Can you make any comment on how the tracking of the rate of increase, what it might portend for those stages in capacity?
Sure. So when we look at the curve, the actual curve, there are a number of curves that you can look at. One is the curve of cases, the number of people who have the infection. And in spite of our under testing, there are some very good mathematical models that have been developed across the country to anticipate the community burden of infection rates. And they factor in population density and total population and a whole host of things. So to some degree that matters, but really what really matters is the hospital curves. So the hospital beds and then the ICU / ventilator curves. Those two curves are what we're really looking at, because that's ultimately what we can measure better, because we actually have numbers on hospitalizations and ICUs and ventilators. And also because it allows us to look at the community as a region. Because when we look at our hospital capacity, we cannot just look at it as Monroe County. It has to be a total region. Because when you look at the current ICU census that I get every day, I think a third or even 40% of the individuals admitted to the ICU are individuals who do not live in Monroe County. They live in the surrounding region. And so when you draw out these curves, we have to consider how local healthcare patterns drive individuals from surrounding counties up here to Monroe. But so when you look at those curves, the big question that we're trying to contend with now is whether those curves are growing at an exponential rate or a linear rate or a polynomial rate, which is somewhere in between. The linear rate is sort of the best case scenario. Okay, that means that everything's going up at an equal rate every day, and you can predict very well because it's a line. The exponential rate is the one that we're afraid of, and we're not seeing any evidence of that right now, but that is the thing that we have to prepare for. That exponential rate is the surge, it's the spike that can happen, to some degree without warning. We do have some warning because we see numbers go up every day, and as numbers go up, there are fewer and fewer people in the community who can become infected. And so there is a little bit of a mathematical juggling act that happens when you do these models. But right now, particularly for the last week, we've been looking at an almost linear, if not barely polynomial rate. And that is reassuring, but that does not mean that we don't prepare. We still have to prepare for the surge. It just means that as we gain more data, we'll have a better idea of how much lead time we're going to need in order to fire off phase 2, phase 3, and ultimately phase 4.
Okay, do I get another question, or is that it for me?
That was your 2, sorry.
Okay, I thought it was a follow-up, but I'll take it. Thanks.
All right, well, with that, I want to thank you all for your time. I appreciate this opportunity to talk to all of you. Like I said, I wish I had more time in the day to share what we know, but again, thank you for all the hard work you're doing. We will get through this together, and I hope it's going to look better for us all on the other side. So thank you all very much.
Thank you, Dr.